Thank you and welcome to everybody. As part of the Ontario Osteoporosis Strategy, Osteoporosis Canada and Women's College Hospital have collaborated on the development of an interprofessional education series Beyond the Break. It is targeted toward health professionals working with people living with osteoporosis. This modular series is designed to provide updates on the latest advances in recognition, diagnosis, treatment, and education on osteoporosis. Today's forum is going to be held by Dr. Papaionou. Yeah, well, I knew I'd stumble over that anyway. So, anyways, Dr. Papaionou is the Professor of Medicine, Division of Geriatric Medicine at McMaster University. She's the Scientific Director of the Jaris Center at Hamilton Health Sciences. She's also the past chair of the Osteoporosis Canada Board and the past chair of the Scientific Advisory Council. She is the lead author on the 2010 guidelines for osteoporosis and the lead author of the 2015 guidelines for the frail elderly. So I'm just going to turn this over to Alex now, and you can save your questions to the end. Thank you.
Okay, thank you everybody for joining us in your valuable lunchtime. And so we're really delighted that you're joining us to deal with a very important issue facing seniors in Ontario and their families as well. On behalf of Osteoporosis Canada Scientific Advisory Committee, we'd like to acknowledge the following authors from across Canada who contributed to the development of the recommendations for the frail elderly. And these are my speaker disclosures. And we received support from CIHR and the Ontario Ministry of Health for the long-term care strategy. So our objectives today are to learn how to apply the 2015 fracture prevention recommendations for frail older adults in long-term care. Having said that, frail older adults who could be residing in long-term care often reside in their own homes, receiving home care, or in assisted living or retirement home. We want to learn about improving fracture risk assessment and how to identify residents at high risk. And do you need a bone density in these frail older adults? Integrating non-pharmacological and pharmacological therapies to reduce injuries, which is the most important injury, is a hip fracture post-fall. So how common are fractures in older adults in long-term care? We'd like to thank Wentworth Heights here in Hamilton, who participated with us in filming this video, and one of the Schlegel villages in Ontario. Prevalence of fractures in long-term care, much higher than that in the community. It's 2 to 4 times higher in this frail older adult. And 1/3 of all those who show up in our emergency rooms in Ontario with a hip fracture are from long-term care. Very importantly is individuals who have that curved back. It's not normal aging. 30% to 40% of them have had a spine fracture. And this is often the first sign before the hip fracture. So what is the impact of fractures? You can actually see it in this lady receiving her medications as people go from being able to walk in their homes in long-term care to being in a wheelchair. And that really summarizes it the best, but I'll give you some of the statistics. 10% of those who break something are going to break again within a year. When you fracture in the community, 20% will end up in long-term care. And long-term care is as expensive as acute care. We've done a recent economic review of the cost in Canada, and it was really quite shocking as somebody who works in the hospital system to see that long-term care is as expensive as our acute care costs. And the biggest side effect of a hip fracture is that 40% of people from long-term care who experience a hip fracture die. So what are the pearls? Highest risk of death is in those from long-term care who are over 90, who don't have an operation to fix the hip fracture, and who score very impaired on the MDSRI, a tool used in long-term care and home care on the cognitive performance. So those who are quite impaired with dementia. So we really like to thank Devora Greenspoon, who has been our poster lady for this story. She really helped shape the story around the recommendations. She was featured in the Globe and Mail. So she went for an independent lady who was driving in the community to residing in long-term care because she fractured her spine, needing a walker. And when you hear her story, I'd encourage you to go to our Jairus website and hear her story on the impact the spine fractures had on her life. The fracture care gap. Despite therapies that can reduce fracture and reduce your chance of dying, pain, and not being able to walk, only in Ontario, 30% of our seniors are receiving assessment and treatment after fracture. So many go untreated when we have good therapies to prevent the next fracture. What are some challenges in long-term care? A lot of the research, a lot of the tools developed have been done in the community and more robust seniors. Those residing in long-term care often are faced with dementia, have swallowing difficulties, and kidney disease, and that's very important to be aware of, as many of the drugs have to have their doses adjusted. Many guidelines that we develop, say for heart, diabetes, are not tailored to frail seniors who have multiple problems and a limited lifespan. So what are some barriers to implementing osteoporosis and fracture prevention guidelines in long-term care? We've just talked about the patient factors or the resident factors. There's practice-related ones, who to treat, who is going to derive benefit, what are side effects. When should you assess for fracture? Long-term care are faced with a number of pressing issues. We know from the staff that when an individual is admitted to long-term care with their family, that's the best time to ask them about these questions. And we know that the long-term care setting is a very busy place, posing some challenges. And this is work from Canada and Ontario from the Ontario Osteoporosis Strategy. So, in Ontario right now, what is the story? Over 600 long-term care beds, about 60% are for profit. 75% of the care is provided by PSWs. Physicians are off-site. The staff were very impressed, often think of the residents as, that they're really part of the family, and they really treat the residents with dignity, call them by their names, whereas in acute care, they're an individual from long-term care. So what's very important is, and from MDSRI, 13% fall within 30 days in the past, and then also the hip fracture rates have actually declined in Ontario. In terms of knowledge translation, we know we have guidelines, and there are guidelines published every day. There are challenges to getting the guidelines into practice, and that's why we're really delighted you've joined us today. One of the studies that we did that really highlighted best practices to get the guidelines into practice was VITOS, and this is also available on our website. We tried to improve the use of calcium and D in long-term care. And this is what works, not just in osteoporosis, but just doing one thing. For you to attend this meeting today does not change your practice. You need to do several things to change practice. One of them is small group learning, an opinion leader like myself today, learning modules, and there's other slide decks available both in English and French on the website, audit and feedback. Physicians particularly are very competitive. They like to know, are they doing the right thing for their patients? So audit and feedback is you're benchmarked across your peers in Ontario to see, are you doing the right thing? Action planning. How do we improve care? You really need to go back to the homes and say what works at your home. And point of care tools are decision aids, and we have a number of them on our website, and also go to Osteoporosis Canada's website. They have a number of resources there that are excellent. And this shows you some of the improvements that we saw in this study. What the staff found was that these are the following recommendations that will really improve care in their homes. On admission, having standard order sets, and there's copies of these on our charts. We also have on the websites, Osteoporosis Canada's website, we also have order sets for those discharged from in acute care that are very helpful if you don't have order sets in your hospital. Having an osteoporosis champion, medication alerts. In the long-term care setting, the pharmacist review all the medications every 3 months with the physician and nurse. And this is a good time to say, has the individual had a fracture? Should we be assessing for falls and fractures interventions? Involving your dietitian in improving calcium intake overall rather than adding more pills. So what is the goal of the fracture prevention recommendations? The goal, we really asked families and residents what they wanted the goals, and their goal is to reduce immobility, pain, transfers to hospital, and the quality of living of residents. So what are the recommendations? In order to reduce fractures, you need to assess for falls risk factors as well as including osteoporosis assessment. All of your falls algorithms should have osteoporosis assessment integrated into them. And there's a number of homes that have reached out to us, such as extended care, to integrate osteoporosis assessment into their falls practice. So how were the recommendations developed? Previously, when we did guidelines, we would just say, is a trial done properly? Was it well thought out? Now we look at the quality of the evidence, balancing harms and benefits, and what are the values and preferences of the end user, the families and the residents, and the frail older adult, and what are the resources? So this is a very different approach. So people often ask about balance training, and here's an example of some of the balance training that you can do in the home. What do the recommendations look like? You'll see we've said strong recommendations. That means for clinicians, most individuals should receive the intervention. For conditional recommendations, we suggest clinicians recognize that different choices will be appropriate for each individual, and you need to assist the families and the residents in coming to the best decisions based on their values and preferences. When we look at the evidence, we say high when we think it's confident that the true effect lies close to the estimate of the effect. In most of our recommendations, we've said moderate to low because much of the research may have not been done in the long-term care setting, and we needed to look at other data to support our recommendations. So how do we assess fracture risk in long-term care? We're doing some very exciting work with Dr. Hurdes at the University of Waterloo using MDS-RI, so stay tuned. Our recommendations, our risk assessment will be able to identify those at very high risk of fracturing within a year, and it's tailored to the frail elderly. But currently what we're recommending is older residents in long-term care. There's two groups, high risk and those not at high risk for fracture. So this lady, I just want to point out, when I mentioned about vertebral fractures, if you saw this patient in front of you or this resident, you should think, has she had a vertebral fracture? You can see she's kyphotic, that her head's pointing forward, and thinking about ordering, when you order a chest x-ray on admission, to add, rule out compression fractures of the spine. Because you can actually see a lot of the spine all the way to the thoracic, that's the point 12, where you turn at the spine, often on the chest x-ray. People are somewhat familiar with tools that we use to predict fracture. One is called FRAX, that is used throughout the world, and one's CAROC, tailored to Canada. If we were to use these tools, and one requires a bone density, you can see FRAX femoral neck. That would mean over 80% of folks would be at risk for fracture. And we don't believe that that's the truth. It may overestimate the effect. If you were to use this tool without a bone density, it would be close to 100% would be at risk. And our tools that we've developed are much more sensitive and specific. So at this point, what we're recommending is, on admission, have you ever broken your hip? After the age of 50, have you lost height? For those greater than 6 centimeters historically. Normally you can put 3 fingers between your rib and your pelvis on each side, and that shows us that they probably haven't had a spine fracture. If you can't, you need to think about a spine fracture. Have you broken any bones after 50? So typical fractures that are osteoporosis related include your femur, your humerus, your wrists. Those will be very typical. What about medications? We've identified steroids, but really important with choosing wisely campaign that is being promoted throughout North America, that we review, are they on psychotropic drugs like benzodiazepines that need to be reduced? Should their SSRI, which is a type of antidepressant, be reconsidered? Why are they on it? Another very commonly prescribed drug in Ontario and in Canada is proton pump inhibitors for reflux, and often residents will be put on these when they're in hospital in acute care and continue on for life. And also have they been on osteoporosis medications in the community. And we have a number of tools we're developing that will highlight these questions on admission. So here is the flow chart. This is the beginning of the flow chart that you would look at on admission. So if the answer is yes to any of the previous questions, the resident is high risk. So again, here's some examples of balance training. And resistance and balance training are very important to prevent fractures no matter at what point you are in life. Walking is not enough. What are the recommendations for calcium and D? So for all residents, we recommend dietary interventions to meet what is recommended for all Canadians over the age of 70, which is 1,200 milligrams of calcium or 3 servings of dairy or dairy equivalents. For residents who are at high risk who can't get that, then we recommend a calcium supplement up to 500. Previously, many people were taking 3 a day or 2 a day, causes a lot of constipation and bloating. For residents not at high risk, we suggest taking a daily supplement. Evidence isn't as strong, so this is just a suggestion. Vitamin D, we recommend 800 to 2,000 units of D3 for those who are high risk, and for those who are not at high risk, we just suggest. The majority of the evidence to reduce fractures and falls has been at 1,000, and there's really no evidence to use this widely in the seniors in the community unless they're on osteoporosis medications. So what is the impact on fractures? It's moderate. You would reduce 15 hip fractures. You'd have 15 fewer per 1,000 for those who are at high risk. And this is the Americans, the Institute of Medicine report. And you can see our little graphics has slid down in the 14 to 18. It's meant to be at those over 70. You can see that we're on par. And I wanted to highlight for those over 70, the upper limb intake level should be vitamin D of less than 4,000. Above 4,000, it means that you have to monitor their calcium serum levels. What are recommendations for exercise? And here you can see some strength training that can be done in a chair. For residents at high risk of fractures, we suggest balance, strength, and functional training exercises only when part of a multifactorial intervention to prevent falls. So those who are at high risk, you need to look at other falls risk factors, because if you get those folks mobile and you don't look at the other reasons while they're falling, you may actually mobilize them and they fall more. For those residents not at high risk, we suggest balance and strength training and functional exercises to prevent falls. Why we've said only suggest is because the evidence and the research is not that strong that it reduces actually falls. But it's a good thing, and it makes people feel better. So in fact, for those who are high risk, mobilizing them may actually increase the number of falls. And this is something that a lot of us in the health field struggle with. So really important to target other falls risk factors. For those not at high risk, you may reduce falls by 660 fewer per year. And for those of you, a lot of times I notice the medical students, their eyes get a bit drowsy when we talk about falls. Every 10 minutes, a senior shows up in an Ontario hospital with a fall. It's a huge, expensive problem. What are examples of balance exercises? This was led by Dr. Laura Giangregorio with a Ministry of Health grant on important ways, and this is available on Osteoporosis Canada and Jerris's website. All sorts of tools, videos from age 50 onward. And you can see for those in long-term care who can't mobilize as well, weight shifting can be helpful in balancing and balance exercises. You can see examples of strength training for the different age groups and abilities. Strength training upper exercises, upper body, and you can go to these sites for more information. And there's a lovely one-pager that you can print off for your clinics. And there's also BoneFit Ontario, where either kinesiologists or physiotherapists who are trained for those who have had fractures and frail older adults, and also individuals over the age of 50, what are the proper exercises. What are the recommendations for the use of hip protectors? For residents who are mobile or are in high risk, we recommend hip protectors. There's really no evidence in the community, and part of that may be the rate of hip fractures and adherence. For those who are not at high risk, we suggest. These are not covered by the government. Some homes or families will purchase them for the senior. And they've changed over a number of years, and they look quite, for people who have incontinence problems, they can be quite, they look like biking shorts, and there's different versions. You can prevent 11 fewer hip fractures for that high risk group, also important. So what are exactly multifactorial interventions for fall prevention? So there's really no evidence that they reduce fractures, but we think it's very important to prevent falls, to reduce the fracture eventually. So it includes medication reviews. So SSRIs, as I've mentioned, have been linked both to falls and fractures. Need to review that. Need to review psychotropics. The individual has settled in the long-term care home. Maybe they don't need that antipsychotic that was prescribed in the community. We know the first 180 days of admission to long-term care are the highest risk time for falls and fractures. Use of assistive devices, Exercise, management of the incontinence is also, and again, we suggest multifactorial because even in the long-term care setting, the research is not robust. The evidence is not as strong. So you'll likely have 660 fewer falls with the multifactorial interventions. And Devora really shares a nice component is when you have spine fractures, you become fearful of falling. When you're curved forward, your whole center of gravity shifts and you tend to propel forward, and it changes your life. So for the high-risk individuals, we suggest dietary calcium, goal 1,000 to 1,200. If you can't get that, a supplement, just one. Vitamin D, 800 to 2,000. We went up to 2,000 because often seniors are vitamin D deficient initially, and more is not better, and we've seen that a lot in the vitamin history, is once a month and once a year actually a vitamin D has been shown to increase falls, and we're not totally sure on the mechanism. For exercise, only when part of a multifactorial program to reduce falls and fractures, and make sure to also look at all the factors. The medication review is a perfect time to review. Is there any drugs we should reassess, decrease the doses and frequency? What about pharmacological therapy recommendations for older adults? So we looked at the benefits and the harms. By balancing these out and doing meta-analysis, we found that you need to live greater than a year to benefit from the medications. And often we know from physician judgment that they're often quite good at judging the length of life in these frail older adults in long-term care, and there's various tools that you can use with MDSRI. So with these medications, you can reduce hip and spine fracture by 40 to 60%. We have drugs called the bisphosphonates. One is alendronate. They're all generic, 70 milligrams once weekly. Risedronate, 35 milligrams once weekly or 150 milligrams monthly, not to be crushed. The majority have to be taken on an empty stomach unless it's Risedronate DR, and they do need to sit upright. And one of the challenges of those with dementia, sometimes they'll pocket their pills, and when you walk away, they won't swallow or they'll spit them out. Contraindications is if there's renal problems. So there's a nice, on your little cell phones, there's a nice app that you can download, and you can quickly calculate creatinine clearance for those of you in the community, but you can also do it, your pharmacist will also have done it for you in long-term care. Despite us knowing this information, we still have doctors and pharmacists sometimes that don't adjust drugs properly and cause and results in some very significant consequences. Other options for those who have difficulty taking those oral medications or have side effects, difficulty swallowing, you can use denosumab, a rank ligand inhibitor, 60 milligrams twice a year. It's just like a flu shot. And zoledronic acid, which is an intravenous drug, a bisphosphonate, once a year, needs to be given over 35 to 45 minutes. These drugs build bone by up to 10%, but they mainly prevent the bone breakdown. With denosumab, you really have to be careful that they have adequate calcium. With zoledronic acid, if their creatinine clearances are less than 30, you shouldn't prescribe them. What's interesting is we have a drug called an anabolic, which builds bone, which is teriparatide, and it actually builds broken bones. It has good evidence for spine fracture, but not for hip. But we've only said suggest because it's very costly. It's not covered by the government. It's only covered by the government if you've had osteonecrosis of the jaw or an atypical fracture. We've suggested not to use etidronate or raloxifene. because there's very weak evidence for hip fracture, and raloxifene can be associated with clots. So all these drugs, the bisphosphonates that I talked about and denosumab, can rarely be associated with osteonecrosis of the jaw and also what we call these atypical fractures of the long bone of the leg. They're rare, 1 to 100 out of 100,000. So for every 100 hip fractures we prevent, you may have one of these rare side effects. And often patients will have a warning sign for at least up to a year before the atypical. It'll feel like a toothache in their leg. So, is the resident's lifespan greater than a year? Consider what their creatinine clearance is like, and then adjust appropriately. If the resident has dysphagia, then we recommend denosumab or zoledronic acid. If they don't, then the cheaper first-line version would be alendronate and risedronate. So, how many fractures will we prevent? 25 out of 1,000 fewer hip fractures, 100 out of 1,000 fewer spine fractures, and spine fractures really are those patients that have them. When you put them in a chair, after about 20 minutes they'll yell to be put back to bed because that decompresses the spine and takes the load off the spine. So prolonged sitting, standing, folks with spine fractures that are fairly severe can't tolerate prolonged sit. And when you think in long-term care, we never put people up, sit them for 15 minutes before bed. They're up for a couple of hours. And so some of that agitation, think when somebody's kyphosis, is it related to the fracture? And we'd also have 20 fewer non-vertebral fractures, which means the wrists and the long bones. And the bottom line is it prevents that transfer to acute care. Seniors repeatedly tell us in Ontario they want to remain in their home, whether it's long-term care or their own home in the community. So in summary, think about fracture on the resident's admission. Think about fracture every time the resident falls. So if somebody all of a sudden becomes agitated post-fall and they're having some difficulty weight bearing or their difficulty with sitting, have they had a spine fracture or another type of fracture? Calcium and D, think about that. Are they on too much or not enough? For your home, what exercise program can be tailored for your home? You could have a physiotherapist advise, the kinesiologist, or the recreationist in your home. And for those who are at high risk, you can reduce fractures by 40 to 60% within a year and prevent the transfer. The good news in Ontario is in long-term care, it's the only sector that we've seen a reduction in hip fractures in the past few years. And we recently published that information, and we're really excited that we're seeing that trend of decreasing hip fractures. And I think we can do even better, and really we'd like to also thank the residents and the family councils of Ontario because they've been strong advocates that this is an important issue for them. So I'll stop there to cover any questions. On the CMAJ website, I should add, is we have our publication. There's a podcast, but there's also quite a lengthy document that was not published in CMAJ, but it's online, that shows you all of the evidence. Then there's French resources on our website as well.